Thank you very much, Dr. Mohan and the organizing committee for honoring me with this R.E.MA Mohan Gold Medal oration. It's a real honor for me to get this. I know you just heard about Dr. R.E.MA Mohan, but I would like to also stress why she's so important in this field. So she had a very short lifespan physically in this world, but I should say she's present everywhere. You can see her here. She has been, for those who know them, her, including me, she's in the bottom of everyone's heart on diabetic retinopathy. She's a pioneer in diabetic retinopathy management. She's an excellent clinician, a researcher. You won't believe it, she had diabetic retinopathy PhD in 1996. She went to Eva Corner to have her medical retina fellowship. If anyone doesn't know who Eva Corner is, she is the chair of the UK PDS study. So she got it right, all her knowledge right from the roots. She's even gone to Wisconsin when the ETDRS study came out to learn about ETDRS grading. So at that time, I think she'll be the unique person who tried to do all this. She's a great teacher. She's an administrator, as you can see. She's done a lot in terms of administration. She's very keen on charitable work. And she is a visionary. You can see how MDRF has grown. I know credit is to many people, but I still think a lot is owed to her. And she had a big ambition, that is to prevent blindness due to diabetic retinopathy, and we are her followers. And it's an apt point to note that the R.E.MA Mohan Department of Ocular Research started in 2024 in commemoration of her 70th birthday. So I think it's all for the better. So on the right, you can see her photo with her personal characteristics, and I think we should all try to become like her. Today, I will go through an overview of the progress made on the legacy of Dr. R.E.MA Mohan. I will cover global health in diabetic retinopathy, screening, and clinical research. She was very keen on that, including clinical trials. So I don't need to tell this audience about the exponential growth of diabetes, but I put this slide up to show that if we don't do anything about diabetic retinopathy or remain status quo as what we are doing today, we will see an proportionate increase in vision-threatening diabetic retinopathy, that is diabetic macular edema, as well as proliferative diabetic retinopathy. These are the causes of blindness due to diabetes. So we have to do something today. So when you take global blindness due to diabetic retinopathy as a whole, we have made significant advances in the treatment of diabetic retinopathy, no doubt about it. We have good diagnostic skills. We have new treatments as well. But if you look at global blindness as a whole, diabetic retinopathy comes up as one of the 5 major causes of global blindness. And it is the only condition that is still increasing in prevalence across the world. Blindness and visual impairment in the patients with diabetic retinopathy usually affects the middle age, young working age group. So it's really clear that we should be doing something about it quite urgently. There are 3 key steps that we could do as a whole to prevent diabetic retinopathy related blindness. And we know that diabetic retinopathy is an asymptomatic disease. People with diabetes do not come to the ophthalmology department unless they have visual impairment, which is a bit too late. So it is actually on the field of non-ophthalmologists to look after screening for diabetic retinopathy. Next is, when you have a screen-positive patient, we should refer to the ophthalmologist for prompt and optimal treatment. I say optimal because it's not enough if you just send the patient over. Treatment is quite intense. In terms of the number of treatments required, it is costly, and we need a lot of patient compliance as well. And lastly, but most important, we need to improve the awareness of diabetic retinopathy-related blindness amongst us and the public. So why is screening so important? We know that annual systematic screening of diabetic retinopathy reduces the rate of blindness due to this condition, and we have seen that in UK, Iceland, Sweden, Denmark, Singapore, etc. And you can see that there is something common about these countries. They are high-income countries with small population. They are small countries, so they can afford annual screening. And you can see here, they are the ones who have reported that they can reduce the rate of blindness. But we are nowhere near there in India. And if you look at it as a whole, 90% of people around the world with diabetes do not have any, they are not subjects to DR screening. So that's where we should act. And for UK, for example, to declare that their diabetic retinopathy is no longer a common cause of blindness took them 2 decades to reach where we are today. So global translation of what we learn from the small high-income countries is insufficient. And a country like India can definitely come up with urgent alternate strategies for treating this condition. So when we take as English National Diabetic Retinopathy Screening Program, we are very proud to say that more than 80% of the patients with diabetes in English system is offered screening. And that is why when they have screen positive patients, they are referred. We have good referral system, and we have good new treatments, because cost is not an issue. NHS is free to everyone who access the system. So clearly, it's very different health system to that in the UK, in India. But we still have challenges in the UK, despite such a good systematic DR screening. And that's because minor ethnic groups with type 2 diabetes have very high prevalence of DR and vision-threatening diabetic retinopathy compared to the white counterparts. Visual impairment is also higher in minor ethnic groups. If they are non-attenders, they have higher rates of diabetic retinopathy. And these non-attenders are usually the younger age group. Socioeconomic status does not seem to have a great role. And the current system is, of course, not cost-effective even for UK. So we are also working on personalized screening, as mentioned earlier. So why is this important? Because 3 in 4 people of minor ethnic group, they live in low and middle income countries. And 3 in 4 of them have diabetes. So clearly there is a global disparity in terms of where the homes of people with, of minor ethnic groups are. There's also a disparity in the prevalence of diabetic retinopathy and vision-threatening diabetic retinopathy. On the left, you can see the prevalence of diabetic retinopathy. You can see where India is, and India is really having high prevalence of diabetic retinopathy. India, together with Southeast Asia, are the 2 major areas with high population, as well as they are still are low middle-income countries with I would say, not optimized health system, and therefore at risk of increasing blindness due to vision-threatening diabetic retinopathy. There's also a big problem in that if you look at diabetic retinopathy research, most of the research are conducted in the areas shaded in green, and that is in the white population. But the problem here is in the minor ethnic group, and therefore I just highlight the need for more research from India and China, for example. So what are the current challenges in diabetic retinopathy screening in India? So Dr. Anjana and others have published that there are more than 100 million people with diabetes compared to 6 million in UK. So you can see the difference. And out of this 100 million, we have to identify the patients with vision-threatening diabetic retinopathy to treat them optimally. So there's a high prevalence of undiagnosed diabetes. Diabetic retinopathy is not a health priority in India. Primary care is still under development. There's poor access to healthcare for many patients. Diabetic retinopathy management is expensive, and they have to use out-of-pocket expenses to go through their treatment. There's a lack of awareness of diabetes and related visual impairment, and diabetic screening is left to the ophthalmologist. I take this opportunity to say that we have very few ophthalmologists in India. There are only 18 ophthalmologists per million population. There's no way people with ophthalmologists can deal with the screening problem. Secondly, there's only 1,100 registered retinal specialists who can treat patients. And patients do not come to an ophthalmologist unless they're visually impaired. So please take this into consideration. It should be the non-ophthalmologist who should be screening for diabetic retinopathy. So we were very lucky, as Dr. Ranjit just said, we, as a collaboration of 12 centers, 6 in UK and 6 in India, received the Global Challenge Research Fund from the UKRI. And this is called the Ornate India project, where the objective of that was to increase research capacity and capability to tackle diabetic retinopathy. We had over 70 publications, and you can see all the states that have been involved in the study. But I think the most important study was the Smart India study within Ornate India, where we tried to estimate the national and subnational prevalence of diabetic retinopathy and vision-threatening diabetic retinopathy. You can see, as mentioned below, there are approximately 3 million people aged 40 years or above with vision-threatening diabetic retinopathy. I say 40 years because that was our inclusion criteria. If you include those from age 20 or above, it will be far higher. And of which 21 million people with diabetes suffer from visual impairment. This is not due to diabetic retinopathy alone. It may be just because they're not using their right glasses or cataract or glaucoma, etc. So the most important figure we need to remember, the 2.4 million people who are blind, people with diabetes who are blind. So this is a real emergency for India. I should thank my collaborators who were in India, who were very good at disseminating it, not only as a publication in Lancet Global Health, but also in all the media policy and policy makers, so that they're very aware of this problem. And actually, we were not the only group who were working on this. There were so many people, including AIMS, and then the Research Society for the Study of Diabetes in India, the RSSDI. So what has come out of this is that DR screening is now covered by Ayushman Bharat in 12 states. And very recently, on the 17th of July, there was a remark that you can see in the Times of India that says that the experts are calling for DR screening to be made a fundamental right for people with diabetes by 2030. So clearly, anyone who has seen the patient the last visit who has not screened the patient has legal implications here. Diabetic retinopathy screening, they also pleaded that diabetic retinopathy screening be part of national NCD program, and also to maintain a diabetic retinopathy register for blindness due to diabetes in national program for control of diabetes. If we follow the same diabetic retinopathy screening program in India, in UK, we would need 4,230 crores to run such a program in India, and clearly that is out of question. So we do need to find out how we can cost effectively screen patients with diabetes. So the risk-based screening is mentioned several times. The 3 important points we need to look at is who to screen, when to screen, and how to screen. So the RSSDI, together with the Vitreoretinal Society of India, has come up with the guidelines which shows that type 1 diabetes of more than 5 years duration, any person with newly diagnosed diabetes and so on, and ongoing, and pregnant women with history of diabetes should be screened for DR. And if they are absent, DR is absent, it then based on their their systemic control, they can be rescreened either at 6 months or a year. If DR is present, they should be referred to an ophthalmologist. So there are various models of diabetic retinopathy screening. You can be hospital-based, and that's where you are all here today. It can be clinicians, physicians, diabetologists, primary care physicians, etc., who can deal with diabetic retinopathy screening. You can, of course, do opportunistic screening in the community, and of course, teleophthalmology plays a great role here. So we did the Kerala project to find out whether primary care centers in Kerala can run a diabetic retinopathy screening program, and this was together with the government of Kerala. We screened 4,000 diabetes patients from 16 family health centers from the NCD register using the Remedio handheld camera, but we had to do mydriasis or pupil dilatation to see the fundus well. And it was a teleophthalmology program, so we had to send all the images to Regional Institute of Ophthalmology in Trivandrum to grade the images, and then depending on the results, patients were either asked for rescreen or treated. We had a significant impact in that we were able to show the government that 30% of the patients had diabetic retinopathy. A very important point to note is, although 30% of patients had diabetic retinopathy, only 8.3% of patients were seen in the Regional Institute of Ophthalmology, and I'll cover that later. 38% of these patients were from the middle age group, and 99% of the patients were not aware of diabetic retinopathy. Their cost-effective screening estimation was done by University of Oxford, and they showed that it only costed 400 rupees per patient screened using this teleophthalmology method. Because of this, the government of Kerala then made it a policy, and today 200 family health centers across Kerala has got a diabetic retinopathy screening program. So the big question is, what did we learn from this? Firstly, diabetic retinopathy screening is cost effective. However, teleophthalmology in such a setup is not scalable, because it was very difficult for us to send these patients' images across to Regional Institute of Ophthalmology, because either there was no current or there was no AI facility, etc. So, and also the results were obtained only 2 to 3 days later when the patients have disappeared from the system. So there was no impact in terms of numbers of patients referred and treated. So that shows that we need other measures. But one good thing we could do with this sort of program is we could use the nurses to educate patients about diabetic retinopathy. And we had to have stage mydriasis, as I explained earlier. This was our biggest challenge in that program or that study. The patients did not think that they needed to be referred, even though we found 30% of them had diabetic retinopathy, because they had no visual symptoms. So this is where we are, and that is why we have to ensure that patients are educated. So ophthalmologists pioneered use of AI in medicine, and we have taken that opportunity. Many people in this audience might have helped to create AI algorithms for DR screening. These AI algorithms can be integrated into handheld cameras. This is a Remedio camera that can hold it. This is very important, because then you don't need to do teleophthalmology. You can inform the patient then and there that the patient has diabetic retinopathy. You can use that opportunity also to educate the patients. And the AI can be improved to include other screening, like screening for glaucoma and AMD. So how can diabetologists and physicians help? So there is a very minimal requirement for diabetologists or physicians to do diabetic retinopathy screening alongside your daily work. That is, you need these sort of AI integrated cameras. You only need a health worker who can be trained how to obtain these images. The AI will tell you whether the patient has to be referred or not. We also can have a patient education with you. And the only important thing is you have to link your center to an ophthalmologist who can manage vision-threatening diabetic retinopathy. Most importantly, you must manage it. I keep a diabetes register, either as an EMR or even if a simple Excel sheet. So it takes only 10 seconds to do these type of photographs. So clearly, I plead with everyone, please buy one. This morning you heard it's cheap, it's affordable. You can just get a technician to learn how to do this, and the camera gives you the report. So you have to trust it, but it's better than opportunistic screening or no screening to our patients at present. These are the type of reports you will get, which shows you, so there's nothing for you to learn from the ophthalmoscope, etc. It gives you what the referral, whether it's need of referral or not. These are other ways of algorithms that can be integrated into these cameras. We can also have LLMs or large language models. Lots of social media material are now available, and there are lots of publication on how to educate our patients with diabetic retinopathy. This is a study done by Dr. Rajalakshmi from MDRF, where they found teleophthalmology can do just as well as face-to-face retinal consultation. So clearly across 35 branches of a chain of DCCs led by Dr. Mohan in 20 cities in India, they could use 30 DCCs to use teleophthalmology, and only 5 centers to use face-to-face fundus examination found that teleophthalmology in diabetes is feasible and effective. So this is a clear example where diabetes centers can manage DR screening. We also can, of course, do charitable work, but make sure we have a register to ensure which patients have been screened, and these are some examples from India. So there is a portfolio of retinal screening algorithms available. We can screen for diabetic retinopathy anywhere. It can be on a bike, a van, a door-to-door. Clinics, diabetologists, physician clinics, optometry shops, medical stores, supermarkets, you name it, we can do it. So if we do it with this sort of AI integrated camera, I don't say they are perfect, but at least they are better than today. And then you have an immediate reporting system, either printed out and given to them for timely referral, or have a connection with an ophthalmologist. We will get there. Now, risk-based screening, we spoke about how to screen, now who to screen. Of course, every patient with diabetes needs screening, but we are at the phase where we have 100 million people with diabetes and 3 million people vision-threatening diabetic retinopathy. So how do we triage our patients so that the vision-threatening diabetic retinopathy patients are identified? So this is again another study with MDRF. Dr. Rajalakshmi and a group of us in UK tried to do whether serum cystatin C could be used as a triage. So you take a blood test, measure serum cystatin C, and if it is high, you know that this patient may be having vision-threatening diabetic retinopathy in their eyes if you don't have their cameras. Now, this was externally validated by a second study by Dr. Rajalakshmi, and you can see that it actually does, cystatin C level does increase with increased severity of diabetic retinopathy. This is the odds ratio that shows a value of 1.1 or above carries a high odds of vision-threatening diabetic retinopathy. We can also have preventive models. This is another study that we did with MDRF and with Wales and with QUML to see how we could predict diabetic retinopathy from very low resourced requirements of the predictors like age, gender, the number of or type of drugs they are on, and duration of diabetes. So very simple ways of identifying those at risk that need immediate screening. The government of Kerala also asked, yes, it is cheap. Yes, you can identify all these ocular conditions. Can you do anything more with retinal photographs? And yes, we heard a talk earlier, diabetic retinal imaging can of course give you much more information on your cardiovascular health, on your diabetes, kidney function, and I think dementia, etc. So here, how can diabetologists and physicians help with DR prevention? So I've spoken about screening, I'm going to stop there. Prevention, we heard that this morning, all the guidelines were very well revised today by all the speakers. So we know that diabetic retinopathy is preventable. And we have done a big study in the CPRD database, that is all GP database in UK, and we found that the GP practices which hold the most number of patients with optimal control of their diabetes, blood pressure, and cholesterol levels seem to have less prevalence diabetic retinopathy and vision-threatening diabetic retinopathy. So this just shows that we all need to work harder to control the risk factors for diabetic retinopathy. And here, this is Anjana's work on the ICMR INDIAB program, showing you that the overall prevalence of diabetes is just on the high in India, especially in the urban countries, urban states, and predominantly in the South India. He also shows, it was discussed this morning, about a third of patients have hypertension as well. And dyslipidemia was a huge topic this morning, again showing that HDL levels, low HDL levels are as high as 66.9%. Now, we don't know the role of low HDL in diabetic retinopathy, but we know that low HDL is a cardiovascular risk, and that can be detected by retinal photography. It takes us about 14 years approximately for a patient who is newly diagnosed with diabetes to develop diabetic macular edema. So we have ample opportunities of about a decade to control their risk factors to prevent them to reach diabetic macular edema. Here, this is the Mary Tyler Moore new initiative on how to classify patients with diabetes. So patients with group A are the people with recent onset diabetes or well-controlled diabetes. So they have no DR. And group B are the people who have developed mild NPDR and then have not progressed to vision-threatening diabetic retinopathy. That's group C, and it's only about 6% of patients with vision-threatening diabetic retinopathy. So as diabetologist, your role if you see a patient in group A is to avoid the patient falling into group B, and even in group B, treat them well, for their risk factors so that they don't drop into group C. For prevention of diabetic retinopathy, we had a whole talk today on semaglutide and GLP-1. I'm not covering that, but there was an article, there were publications stating that maybe semaglutide can worsen diabetic retinopathy, but they were all based on short duration studies. So we have the FOCUS trial. There's a 5-year trial looking at the rate of diabetic retinopathy. And I'm hoping that by 2028, we will know whether this is another indication for the new drugs. RAS inhibitors, I'm sure I'm not talking to, I'm not a medical dietitian to tell you RAS inhibitors are very good for VTDR as well. Fenofibrate, we had a discussion this morning which state that if a patient is on statin, we don't add fibrates, but we have several studies now that shows that fenofibrates actually reduces the risk of diabetic retinopathy. So more work may be required to see how we add fenofibrate for our patients. So a poly pill may be the answer, that you have a GLP-1 agonist or SGLT2 inhibitor, add an ACE inhibitor, and any form of fibrate, statins, and you may find that we can reduce the rate. However, this has to be done like an ECHO-type randomized control trial. Group B is prevention of patients dropping from no DR to DR. That's actually our job. And we have tried several things like photobiomodulation. I'm sure you have heard of light therapy for diabetic retinopathy. It does not work. We have tried anti-VEGF therapy for those who haven't developed vision-threatening diabetic retinopathy. It does a cosmetic improvement of the diabetic retinopathy, but it does not improve perfusion. So it is a big challenge for us. Of course, there are new agents that are coming out that are on trial. One example is the tyrosine kinase inhibitors may need to be injected only every 8 to 12 months. So that may be an opportunity. There are also gene therapy trials and port delivery systems that are coming our way as well. So we may be able to improve the durability of anti-VEGF. Group C is the current treatment for diabetic macular edema, and you know anti-VEGF is the current treatment of choice. And we have nice criteria on how to treat. I'm sure you are treating it the same way. But I need to stress that this is a study we did in India, multi-center study looking at anti-VEGF and the visual outcome of people with diabetic macular edema. We have to give approximately 8 injections in the first year. Here, the average injections were 2. So clearly, we can't give the type of injections that are needed for our patients, mainly due to cost and non-compliance. So if we have such difficulties, laser is still a treatment of choice. I did the CLARITY study to see whether anti-VEGF would be useful for proliferative diabetic retinopathy. Yes, it improves visual acuity, but it does not improve non-perfusion, and therefore pan-retinal photocoagulation is still the treatment of choice. So in conclusion, India is on track for better and wider DR screening coverage. There are multiple models need to be employed in India. We need to shift the task of DR screening to non-ophthalmologists. I'm hoping the diabetologists, at least in this audience, and primary care physicians do take this opportunity to start screening for vision-threatening diabetic retinopathy. There's several research need to be done. I'm saying an AI-integrated photography is good, but again, there are issues like data protection, privacy, legal implications, etc. But I still believe that when you don't do anything, you have a further litigation issue than doing something. Awareness program, of course, has to be improved significantly in India, and we need to keep a blindness register for us to assess whether what we are doing does impact blindness. Diabetes and risk factor management, that's up to you again. And evidence-based clinical practice among ophthalmologists is clue, and we have run several guidelines for that. And we have to continue to learn and share knowledge to be effective. So the final slide is sustaining the legacy of Dr. REMA Mohan. Have we done it? Are we doing it? So she liked an increase in human capital. She wanted it diversified, and we are there. You can see the number of people that have to be involved to ensure that people with diabetes do not lose vision. She was also highly collaborative, and we have significant number of collaborative grants. So I think in that respect also, we have done a good job. Scientific efforts in India, yes, she led the path, and I think we should do more. But clearly, India should lead the way in prevention of diabetic retinopathy in low and middle income countries. Thank you.